Now let's move on to discuss some of the drugs used in treating heart failure. The first group we will talk about are the cardiac glycosides. You may have heard this also called digitalis because it is derived from the plant named Digitalis purpurea. Here's an image showing the different transporters on the sarcolemma membrane of our cardiomyocyte. Notice how digoxin competes with potassium for the extracellular potassium binding site of the sodium-potassium ATPase in cardiac tissue. By decreasing activity of the sodium-potassium ATPase, we achieve our main goal of decreasing the efflux of sodium. Why is it our goal to maintain a relatively high intracellular sodium concentration? Check out this sodium-calcium pump right next to all this action. This pump will be sad because an increase in intracellular sodium decreases the transmembrane gradient for it to pump out sodium into the cell and calcium out. Decreased activity of this pump leads to an increased intracellular concentration of calcium, which will be stored in the sarcoplasmic reticulum. More calcium means more troponin C calcium binding, and therefore more actin-myosin interactions and cardiac contractile force. Kinda sounds like an ideal drug for someone with systolic dysfunction, right? It sure is. They need contractility. This is not the only mechanism of action of this drug, though. It is not yet completely understood how digoxin increases vagal tone and inhibits the sympathetic nervous system by somehow working in the brainstem. This is helpful in treating atrial fibrillation with rapid ventricular response in a patient with heart failure. The problem in AFib with RVR is that every weird random depolarization that is originating in the abnormal circuits near the pulmonary veins of the left atrium is passing through the AV node and telling the ventricles to contract. This is a really bad situation because the ventricles cannot adequately fill in diastole if they are being stimulated 250 times per minute. By increasing vagal tone on the AV node, digoxin increases the refractory period so that now every single impulse cannot make it through to stimulate the ventricles to contract. This increase in vagal tone on the heart is beneficial, but you must be careful when giving this drug because you can actually depress the AV node to the point of AV block. In addition, systemic adverse side effects of increased vagal tone can be terrible. Increased parasympathetic tone in the GI tract can lead to some common cholinergic digoxin side effects, such as nausea, vomiting, and diarrhea. Just remember, GI with the digi. GI with the digi. Now what about that blurry yellow vision? Well, the rods and cones that are responsible for taking light and turning it into a signal for your brain are dependent on potassium. Digoxin can inhibit the sodium-potassium ATPase on these cones and rod cells. This disturbs normal potassium concentrations and can interrupt normal signaling because rods and cones mainly use potassium to alter transmembrane potential instead of sodium. This is how you get the blurry green color vision associated with digoxin toxicity. How does digoxin lead to hyperkalemia? It prevents the sodium-potassium ATPase from pumping potassium back into the cell and sodium out. This not only happens in cardiac myocytes, but can also inhibit this pump on skeletal muscle. You can just imagine the amount of potassium that it can accumulate in the extracellular compartment, and sodium along with calcium in the intracellular environment. It is this accumulation of sodium and calcium inside that can shift the resting membrane potential to a more positive value. When our transmembrane potential is more positive, it is a lot closer to depolarization threshold. This is how we are at risk for spontaneous depolarizations that lead to arrhythmias. If we are close to threshold at all times, firing early is a definite possibility. We discussed some toxicities, and there are some things that we can watch out for so that we don't almost kill our patient. You can always just monitor the serum levels of digoxin, but that is not a test question because it's just too easy. Digoxin is excreted renally, so any decrease in renal function can lead to accumulation of digoxin in the patient's blood. Now wait a minute, Pete. You just said that digoxin causes hyperkalemia. So why would having hypokalemia put me at a greater risk of digi-overdose? Well, digoxin competes with potassium on the extracellular sodium-potassium ATPase. If the patient is already hypokalemic, then there will be less potassium ions to compete with digoxin at the pump. This can exacerbate the degree of blockade. Digoxin binds albumin, but so do other drugs like verapamil, amiodarone, and quinidine. If a patient is taking both drugs, you can guarantee that one of these three drugs will compete with digoxin for albumin binding sites. This is dangerous because you can potentially displace digoxin from albumin and increase free digoxin floating around. Well, how do we treat digoxin toxicity? We first need to slowly normalize the potassium levels. We need to make sure we can increase the functionality of the sodium-potassium ATPase pump by giving magnesium. Magnesium is a key cofactor for the pump to work. If we're still worried about digoxin levels, we can give anti-digoxin Fab fragments. These directly bind any free digoxin. If all of this fails, then we need to set up for a cardiac pacer, because the SA and AV nodes can be severely depressed from digoxin's ability to increase parasympathetic tone to the heart. A cardiac pacemaker is a catheter that has an electrode on it. You stick it in the patient's veins and push it through the venous system to the heart so that you can send electrical impulses to trigger the rest of the myocytes to contract. Okay, so you have to know this digoxin stuff, so let's reinforce it with a flash quiz. Digoxin is removed from the body by blank excretion. This is a straightforward question, and so is the answer. We need to know that digoxin is cleared into the urine by the kidneys. This is crucial to remember so that you do not give digoxin to a patient that has signs of a decreased renal function. You need to double check that creatinine for any signs of renal failure. A lot of patients with heart problems also have renal problems due to chronic activation of the renin-angiotensin-aldosterone system, so be on the lookout for this. Alright, let's test ourselves. A 78-year-old woman presents to the outpatient clinic complaining of nausea, vomiting, and diarrhea. Her medical history is significant for hypertension, hyperlipidemia, and atrial fibrillation. She states that for the past 4 hours, everything she sees has a blurry yellow tint. Several abnormalities are detected on ECG, including T-wave inversion, an increased PR interval, and a decreased QT interval. What is the mechanism of action of the medication responsible for these symptoms? We've got this. You have an elderly lady with a past medical history of hypertension, hyperlipidemia, and AFib. Now she's reporting nausea, vomiting, diarrhea, and a blurry yellow tinted vision. Her EKG is screaming hints with inverted T waves, an increased PR interval, and decreased QT interval. This is a really straightforward question loaded with information. First, you have to remember which drug has all of these side effects. Then, you need to consider it and recall the mechanism of action. This is how step 1 will be. Instead of just remembering the drug, you need to take it one step further and also remember its mechanism in addition to recognizing its toxicities. Do you see an option in the answer choices that could cause an increase in the amount of extracellular potassium? Of course you do. E is the correct answer because it explains the mechanism of how we can get high levels of potassium in the extracellular environment. We are talking about digoxin again here. All of the side effects listed on here should be making you think digoxin, especially blurry yellow vision and the GI problems. It should be noted, however, that the mechanism by which the inverted T wave due to the hyperkalemia is not well understood, and it is a specific and unique finding to digoxin toxicity. Can anyone remember what we normally see on an EKG with hyperkalemia? Right, we normally have high peaked T waves. So remember, if you just have digoxin toxicity, then this will be the inverted wave, but a normal hyperkalemia presents with the peaked T wave. The key to understanding the antiarrhythmics is to remember back to your physiology and understand myocyte depolarization and repolarization. All the class 1 antiarrhythmics block the voltage-gated fast sodium channel that are responsible for the upstroke in phase 0 of cardiomyocytes. Your book says that all of this is state-dependent. The sodium channel blockers are in different classes because each binds to the channel when it is in a certain state and for how much time it takes for them to dissociate from that channel. Remember, sodium channels constantly fluctuate between 3 states: resting, open, and closed. We discussed how the fast sodium channel has a voltage-sensitive activation gate that blocks the sodium pore, but will open when there is a change in the voltage due to a depolarization. The activation gate opens and sodium flows in. The transmembrane pore will then be blocked when the inactivation gate swings over to stop influx. Class 1A drugs bind the channel when it is in the open or active state, which is why they are the most useful at very fast heart rates when this channel is open more often due to very frequent depolarizations. Class 1B drugs bind the sodium channels during open and closed states. Class 1C drugs are very potent blockers of the channel when it is in the open state, and they take the longest time to dissociate from the sodium channel, which is why they decrease the slope of phase 0 the most out of any of the classes. Okay, we are now going to go more in depth with each class, starting with class 1A. These drugs, quinidine, procainamide, and disopyramide, block the fast sodium channels in the active or open state. This means that they directly compete with sodium at the transmembrane pore when the cells are depolarizing at fast heart rates. By blocking sodium influx, we will decrease the slope of phase 0. We are decreasing the velocity of conduction because some channels are blocked from allowing sodium influx. This increases the time required to complete the action potential because we have to get a certain amount of sodium to flow across the limited amount of available sodium channels. Remember, these sodium channels are in high concentration in normal ventricular and atrial myocytes. This effect on atrial myocytes is particularly useful in treating supraventricular tachycardias. Supraventricular tachycardia just refers to a fast heart rate that originates anywhere above the ventricles, most commonly in atrial myocytes. The ability of these drugs to bind sodium channels also helps to decrease conductance of ventricular myocytes. This makes them great at treating very fast depolarizations of our ventricular myocytes, which we call ventricular tachycardia. So why do we have a prolonged QT interval? You must remember that these drugs also block potassium channels that are responsible for phase 3 repolarization. Note how this shifts phase 3 on the diagram. This prolongation of phase 3 increases our QT interval and also increases the action potential duration. Let's repeat that to make sure we have this solid in our minds. How do these class 1A drugs work? They block fast sodium channels responsible for our phase 0 depolarization and potassium channels that mediate our repolarization in phase 3. Even more important are the side effects. Side effects are high yield because they can kill patients, or a patient will stop taking the drugs because of the side effects. With quinidine, you need to watch out for its ability to disrupt the sodium channels of the hair cells and other neurons in the CNS, because it can lead to tinnitus and headache. This was first described as synchonism because quinidine is found in the sap of the cinchona tree. When people used to use this sap for medicinal purposes, they would sometimes overdose and experience symptoms including headache, tinnitus, hearing loss, and visual problems. Procainamide is famous for causing a systemic lupus erythematous presentation. Disopyramide is the bad guy here. It has an incredibly potent effect on suppressing the fast sodium channels to the point that it can actually lead you to such a low contractility that you essentially give the patient systolic dysfunction and heart failure. All of these drugs can lead to torsades de pointe, or as you might say, torsades de pointes. So why can all of these drugs lead to torsades? Anytime we start messing around with the potassium channels responsible for our repolarization, we can predispose to QT interval prolongation, and this automatically increases our risks for torsades. One last side effect is thrombocytopenia. No one is quite sure how this works yet, so just be on the lookout for someone with a low platelet count in the setting of starting a new class 1A drug. Luckily, we only have 2 drugs here, lidocaine and mexiletine. Phenytoin can also be in this category because it is a sodium channel blocker, but it is not commonly used to block sodium channels in the heart. It is more for sodium channels in the brain to prevent and treat seizures. Class 1B drugs inhibit the same fast sodium channels that we discussed in the 1A group, but unlike Class 1A, these drugs shorten the action potential duration. How is this possible to shorten the action potential if we are blocking the channel? After phase 0, there are still some sodium channels firing in phase 1 and 2. There are just very few of them. Lidocaine and mexiletine will block these and obliterate this current. This shortens the action potential because we stop the influx of sodium sooner than normal. So why does class 1B preferentially affect ischemic, especially post-MI or already depolarized Purkinje and ventricular tissue? In ischemic tissue, the transmemory potential tends to be around negative 60 millivolts instead of the negative 85 millivolts that we would expect in a healthy heart. Depolarized tissue is also obviously at a higher transmembrane voltage because it just recently depolarized. A more positive transmembrane voltage will require a longer time for lidocaine or mexiletine to dissociate. Okay, so why don't we use it for ischemic atrial myocytes too? Well, these drugs bind the best when cells have a long action potential because they want to bind to channels in the inactivated state. Atrial myocytes depolarize very quickly and give class 1B drugs very little time to bind. But since we were worried about ventricular ischemia in the cases of MI, you should remember that class 1B antiarrhythmics are the drug of choice in acute ventricular arrhythmias. You can remember this with the mnemonic 1B is best post-MI. You can use this for digitalis, aka digoxin-induced arrhythmias. The arrhythmias that are triggered from digoxin use are due to way too much sodium inside the cells. Makes sense to use a sodium channel blocker, right? Right, it is a good idea. Now some side effects of note. Anytime you're depressing sodium conductance by giving a drug, giving too much of it can lead to excessive block and cardiovascular depression. Same concept goes for CNS symptoms. There are tons of sodium channels in the brain. Lidocaine and mexiletine are very lipophilic. They easily cross the blood-brain barrier and cause CNS symptoms. Lidocaine is the classic culprit for triggering seizures. The class 1C antiarrhythmics, flecainide and propafenone, are rarely seen clinically because of the high risk profile. This makes them high yield for written exam though. Dangerous side effects are always high yield. Look at the slope of that diagram. It's a lot less steep when compared to the slopes in 1A and 1B, right? What is that telling us about the ability of the 1C agents, flecainide and propafenone, to block the fast sodium channels? They are super potent and take forever to dissociate from the sodium channel. These drugs are also capable of prolonging the effective refractory period of the AV node and accessory bypass tracts. These drugs are used as last resorts in some refractory VTACs. Unlike Class 1B drugs, you never give Class 1Cs to a patient who just had an MI. The cells in their ventricles have just suffered severe membrane alterations and ion leakage, and they're just waiting for an opportunity to start beating on their own if you block the override signal from the AV node. This is the toxicity of the drug. In the setting of ischemic or structural heart disease, you can give these people arrhythmias. You've got a 67-year-old patient that comes to the ED complaining of palpitations and sweating. Vital signs show a heart rate of 170 and an irregular rhythm on ECG. Beta blockers are among the most common medications prescribed to patients. But before we prescribe them, we need to understand how and why they work. In this lecture, we will cover what is the mechanism of action of beta blockers, what is their clinical use, and what adverse drug reactions can we expect when prescribing them. As you can see, most of the beta blockers end in lol. It is important to differentiate selective or non-selective. We have metoprolol, esmolol, and atenolol. These are beta-1 selective, which means they only block beta-1 adrenergic receptors on the heart, leading to a decrease in heart rate. And contractility, which is why these meds are great for AFib and aflutter. Now what about non-selective ones? We have propranolol and carvedilol. Propranolol is very lipophilic and therefore excellent at crossing the blood-brain barrier. Because of this CNS penetration, it is an ideal drug for migraine prophylaxis. As a side note, propranolol is also used for treating hepatic portal hypertension, thyrotoxicosis, essential tremor, and can even be given to help reduce the size of arteriovenous malformations. Timolol is famous in its ophthalmic form because beta antagonism on the ciliary epithelium leads to a decrease in aqueous humor production, which is helpful in the treatment of glaucoma. Carvedilol is not only a beta-1 and 2 antagonist, but also blocks alpha-1 receptors. This triple antagonism not only decreases the contractility of the heart, but also leads to significant vasodilation by alpha-1 blockade. Okay, let's talk mechanism more in depth. Beta blockers are great drugs if you want to alter conductivity in the heart and in particular,
places that are responsive to the autonomic nervous system, the SA and AV node. Beta blockers compete with epi and norepinephrine at this beta 1 receptor. By inhibiting this receptor, we do not stimulate adenylyl cyclase to produce CAMP. Do you remember the funny current channels that are responsible for the baseline depolarization of pacemaker cells? CAMP binds those channels to increase the heart rate at which they open. If we drive down CAMP with beta blockade, we are going to limit the rate at which those channels open. In addition, the drop in CAMP also limits protein kinase A. Without an active protein kinase, calcium channels on the membrane do not open, and we severely decrease the slope of phase 4 depolarization. Here we can see how phase 4 is super flat and prolonged because we decrease the activity of the calcium channels responsible for the upstroke of the pacemaker cells. Why are patients on beta blockers diagnosed with first-degree AV block? Well, the beta blockers decrease conductance through the AV node. This shows up as a prolonged PR. An excess of this block can lead to side effects such as bradycardia due to increased PR interval on ECG. AV block and heart failure can occur. If you decrease the ability of the conduction system to depolarize, then you can decrease the heart rate, prevent the AV node from conducting impulses, and if the cardiac depression gets severe enough, you can cause acute heart failure. Classically, beta blockers have been associated with impotence. You need to know this because men won't ask for sildenafil or a similar drug to maintain an erection. Patients will just stop taking their beta blocker if they cannot get an erection or if they have difficulty with ejaculation. Almost as important as erectile dysfunction, beta blockers can exacerbate COPD and asthma or vasospasm in Prinzmetal's angina because the beta 2 receptor antagonism triggers smooth muscle contraction. Why is metoprolol famous for dyslipidemia? Well, beta 1 receptor stimulation induces lipolysis in adipose tissue. If you block lipolysis, then you increase the risk of dyslipidemia. Let's talk about the side effect of bronchospasm and vasospasm. Non-selective beta blockers such as propranolol block beta 1 receptors in the heart, but also block beta 2 on smooth muscle cells in the bronchioles and coronary arteries. If you block beta 2 receptors, what does the smooth muscle in the airways and coronary arteries do? It contracts. The smooth muscles contract because the beta 2 receptor is blocked from activation. The G stimulatory protein associated with beta 2 receptor will also be inhibited. It will not tell adenylyl cyclase to make CAMP, and protein kinase A will stay inactive. Protein kinase A is key because it normally inhibits myosin light chain kinase. If myosin light chain kinase is not inhibited because the patient is taking a non-selective beta blocker, myosin will be phosphorylated and the smooth muscles will contract. This can trigger smooth muscles in the bronchioles or arteries to spasm. How do we treat bronchospasm? Well, the same way we treat asthma flare-ups. We give beta 2 agonists like albuterol to relax the smooth muscles lining the bronchioles. In patients with COPD or asthma, they already have bronchial inflammation. The last thing you want to do is block the ability of smooth muscles to relax and help open up the airways. In the case of Prinzmetal's angina, which is characterized by coronary artery vasospasm, it would be a terrible idea to inhibit the ability of the coronary artery smooth muscle from relaxing. What are some other high-yield effects associated with these drugs? How about something we all experience as medical students? Sedation and sleep alterations. The sympathetic nervous system is a key component of the reticular activity system. This system keeps us alert and is also responsible for slow wave sleep. Beta blockers depress the sympathetic component of the reticular activating system. The same situation can be said for the super high yield concept that beta blockers can mask the signs of hypoglycemia. You better know the presentation of a hypoglycemic patient, because that is how you'll be tested on the side effects. A hypoglycemic patient will be acting impaired or slow because the brain needs glucose to function properly. The brain will respond by activating the sympathetic nervous system in hope to tap into glycogen stores. Catecholamines like epinephrine bind beta receptors to the liver to stimulate gluconeogenesis and glycogenolysis to increase blood glucose levels. Patients on beta blockers are taking a medication that antagonizes this response. So not only do we exacerbate the hypoglycemia by preventing the elevation of blood sugar levels by compensatory mechanisms, but we can also hide the clinical signs of hypoglycemia. So what signs are we talking about? The signs that one would expect from an increase in sympathetic outflow: tremor, anxiety, tachycardia, palpitations, mydriasis, pallor, and coldness. The beta blockers we have them on will compete with catecholamines at all of the effector tissue sites that give us this constellation of signs. This systemic beta blockade can also be very dangerous if you give them a patient suffering from cocaine toxicity or pheochromocytoma. Why is this? Cocaine blocks reuptake of catecholamines back into the synaptic cleft. Pheochromocytomas are tumors arising from chromaffin cells in the medulla of our adrenal glands. They are secreting tons of catecholamines. Taking a bunch of cocaine and having a pheo lead to high levels of alpha-1, alpha-2, and beta-2 agonist activity. You should never give a non-selective beta blocker to these patients, because if you beta block these receptors and lose the B2-mediated vasodilation, what are you left with? Well, unopposed alpha-1 vasoconstriction. This can drive your blood pressure way sky high. How do we treat beta blocker overdose? That's right, we give saline, glucagon, and atropine. The severe drop in cardiac output will drop the blood pressure drastically, and we need to give them some normal saline to boost intravascular volume and bring up the blood pressure. This gives us time to fix the underlying problem. Glucagon is a great way to counteract this and also treat an overdose, because it is a potent stimulator of glycogenolysis and gluconeogenesis. This helps raise blood sugar levels. Glucagon also activates G protein receptors in the heart, which causes activation of adenylate cyclase and gives us more CAMP. We know that an increase in CAMP increases the heart rate. So why should we give atropine? In beta blocker overdose, sympathetic nervous system output on the heart is blocked. There is uninhibited parasympathetic signaling on the SA and AV node. Atropine will help us here because it is a muscarinic antagonist. Flash quiz time. Beta blockers function by affecting what portion of the pacemaker action potential? The answer is decreasing the slope of phase 4 of depolarization at the AV node. In this video, we learned that beta blockers decrease SA and AV nodal conduction by calcium channel blockade. They are clinically useful in SVT and AFib and atrial flutter. And there are a variety of adverse reactions patients can expect to experience, including bradycardia, dyslipidemia, and impotence. Thanks for watching, and be sure to click thumbs up if you enjoyed this video.
Okay, so the third class we need to evaluate are the potassium channel blockers: amiodarone, ibutylide, dofetilide, and sotalol. All of these bind the potassium channels responsible for repolarization in phase 3. This delay in repolarization prolongs the action potential and increases the effective refractory period. Anytime we prolong repolarization, we are also prolonging the QT interval. Any drug that prolongs your QT interval can set you up for that deadly French arrhythmia, torsades de pointe, or as some of you might say, torsades de pointies, whatever your flavor. These drugs are useful in the treatment for obliterating re-entry circuits that are the cause of atrial fibrillation, atrial flutter, or ventricular tachycardia. So how do these currents work? Well, normally, the action potential starts in the atria and travels down the interventricular septum to the Purkinje cells to contract the ventricles. Alright, so let's say we have something here. It could be anything within the myocytes, a blood vessel, a nerve, whatever. When the action potential current is coming down, I want you to think of the head of the arrow as the initiating potential and the length of the arrow as the refractory period. So the action potential is going along its way, and when the current moves around the obstruction, the two initiating potentials cannot continue. So the currents cancel out. No big deal. The heart still contracted from the other traveling currents. However, if we had something like ischemic tissue around our little blood vessel obstruction, this damaged tissue and the normal tissue could have different refractory periods, which will cause the current to only be able to move in one direction. So the next time that an action potential comes down and around, it can only move around the obstruction in one direction. And since the refractory periods may not be as long, the current gets stuck in a loop of depolarization called a re-entry circuit. This causes the loop to fire and fire and fire rapidly and repeatedly and cause a tachycardia. Oh my God, Pete, why does all this matter? Alright. One last time. Let's say we have our little obstruction and we have our ischemic tissue. But now we're given a drug that has lengthened the refractory period. So this time, when the current goes around to the area where we had the re-entry circuit, the last action potential has not finished firing yet. And using a class 3 antiarrhythmic, we've essentially prevented the ability for that constant firing to occur. Because amiodarone is the most used drug in this class, and it has a high yield side effect profile, we will talk about it first. Amiodarone is very lipophilic and is metabolized very slowly by the liver and then excreted by the skin, bile, and lacrimal glands. Just knowing the metabolism and excretion can help you remember that it can lead to hepatotoxicity or corneal and skin deposits. Amiodarone can act as a hapten to trigger a hypersensitivity like pneumonitis in the lungs and a photodermatitis that appears as inflamed blue skin. Well, what about thyroid toxicity? Check out the two iodines here on the structure of amiodarone. Which organ in our body takes and uses lots of iodine? The thyroid, right. Amiodarone will get taken up into the thyroid where it can then cause a direct toxic effect on thyroid follicular cells. Cell damage can liberate thyroid hormones and initially lead to a hyperthyroid state. As the continued inflammation continues, the thyroid function drops and the patient becomes hypothyroid because the thyroid isn't making anything. Because of the ability of amiodarone to cause pulmonary fibrosis, hepatocyte injury, and thyroiditis, you need to check pulmonary function tests, liver function tests, and thyroid function tests on these patients. What about neurologic effects, constipation, and cardiovascular effects? Amiodarone is not limited to potassium channel blockade. It is also capable of blocking sodium and calcium channels. Neurons are particularly dependent on sodium channels for sending signals, so neurologic effects such as paresthesias and weakness are potential side effects. Calcium channel blockade of smooth muscle in our intestinal tract can lead to constipation, and calcium channel antagonists in the SA and AV nodes can lead to bradycardia, heart block, or even heart failure. Amiodarone isn't the only one that lacks channel or receptor selectivity. Sotalol is an antiarrhythmic that is made up of two stereoisomers, D-sotalol and L-sotalol. The D-sotalol blocks potassium channels and acts like a class 3 drug. The L-sotalol acts like a beta blocker and competes to antagonize beta-adrenergic receptors, which is why you need to watch out for excessive beta blockade. Alright, let's test our muscle with another question. In the emergency department, an 80-year-old man with an implantable cardiac defibrillator has persistent episodes of ventricular tachycardia despite attempted cardioversion. He is admitted and started on oral amiodarone. His ventricular tachycardia improves and he is released. However, weeks later he begins to manifest drug-associated adverse effects. Which of the following signs and symptoms would suggest amiodarone toxicity? So, kind of a long vignette with the punchline of, do you know the toxicities of amiodarone? You don't even have to know all of them to understand the question, but you should for real-life patients. Which one of these is a possible toxicity of amiodarone? We talked about how amiodarone contains a lot of iodine, so it can cause thyroiditis. If we are damaging the thyroid gland, T3 and T4 can leak out of the thyroid initially to cause a hyperthyroid state. Do you see any answer choices that would reflect high levels of thyroxine and triiodothyroidine? That's right, the choice is E. E describes hyperthyroidism. Weight loss, hyperreflexia, and chest palpitations are all signs of amiodarone causing damage to the thyroid, resulting in leakage of thyroid hormones. Well, what about these other answer choices? We know amiodarone can damage the lungs, so some of you might have wanted to jump all over B. Now remember that amiodarone causes pulmonary fibrosis. The increased fibroelastic tissue will actually increase FEV1 because the excess elastic tissue from fibrosis is like adding a huge spring. B cannot be the answer because the FEV1-FEV ratio would actually increase, not decrease. Deep venous thrombosis and hypertension are not what is going on in this patient. Dysuria, hematuria, and flank pain in option C are described in some of the signs and symptoms of acute pyelonephritis, not anything related to amiodarone toxicity.
In this video, we will only be discussing the non-dihydropyridine calcium channel blockers because these medications are more cardiospecific and are therefore effective for treating arrhythmias. Do you recall where dihydropyridine acts on? Right, they relax the smooth muscles on the peripheral vasculature. Our goals for this lecture are to understand what is the mechanism of calcium channel blockers, what are its clinical uses, and what are the adverse effects that we can expect. Verapamil and diltiazem are non-dihydropyridine calcium channel blockers. They do not end in dipene like the dihydropyridine calcium channel blockers. The class that the calcium channel blockers belong to determines how selective it is for the myocardial or vascular smooth muscle cells. Verapamil is highly selective for the myocardium, while diltiazem has an intermediate selectivity for both cardiac and vascular smooth muscle channel receptors. Both of these L-type calcium channel blockers decrease the slope of the pacemaker action potential because of the decreased influx of calcium that is responsible for the upstroke of phase 0. What does this look like on an ECG? It leads to an increase in the PR interval. Remember, the PR interval represents the period in which the conduction velocity is delayed through the AV node. Why do we prolong the repolarization in the AV node? Well, the potassium channels that open to allow the efflux of potassium for repolarization open when they have been activated by the calcium influx. If we are blocking the calcium channels responsible for changing the voltage to open the potassium channels, it's going to take longer for all those potassium channels to be activated. Therefore, we lengthen repolarization. This prolongation of repolarization also has an effect on the number of available calcium channels for the next depolarization. We increase our effective refractory period because we only have some calcium channels available for a local impulse, and we need to wait longer to create a full action potential that will propagate. For this reason, these drugs are helpful in rate-controlling atrial fibrillation. We use them to reduce the rate at which the AV node responds to atrial depolarizations. We do not want every single wave of depolarization from a fibrillating atrium to be conducted by the AV node into the ventricles. We want the AV node to be refractory to more depolarizations to control the rate of ventricular contraction. Same thing can be said for supraventricular tachycardias. Supraventricular just means that something above the ventricles is responsible for the fast or tachycardic rate. The problem in SVT is that there is an impulse traveling in loops through the AV node. It is constantly depolarizing the atria and ventricles because it is a loop of depolarization in the AV node that is re-entering on itself over and over again. Verapamil and diltiazem increase the refractoriness of the AV node so that one pathway of this loop will be refractory. When hit by the depolarization loop, this terminates the supraventricular tachycardia. Okay, so now we need to discuss the side effects. If we decrease calcium conductance in the pacemaker cells excessively, we could end up causing sinus node depression, AV block, and even acute heart failure if we depress our heart to the point that it is unable to contract efficiently. So what about the constipation, flushing, and edema? Well, remember that we're blocking calcium channels, so we can also start blocking them in other locations, including the interstitial cells of Cajal that are responsible for the slow wave potentials that cause the intrinsic peristaltic movements of the intestines. If you block these calcium channels that are going in the intestinal smooth muscle, you better believe that your patient is going to feel constipated because their gut has decreased contractility. The flushing and the edema are due to the excessive vasodilation for blocking the calcium channels responsible for vascular smooth muscle contraction in the skin and extremities. When vessels near the skin surface dilate, you can see redness and even feel the heat coming off the blood inside of them. The very dilated vessels can also get leaky and allow some transudation of fluid into the interstitium, which produces edema. Flash quiz. What cardiovascular effects can be observed on an ECG? The answer is prolonged PR interval. Remember, the PR interval represents the period in which the conduction velocity is delayed through the AV node. Alright, so in this lecture, we covered that calcium channel blockers act by decreasing the conduction nodal velocity. They are clinically useful in the treatment of SVT and atrial fibrillation by preventing nodal arrhythmias. And some adverse drug reactions to tell your patients about are constipation, flushing, swelling, and cardiovascular depression. Thanks for watching, and be sure to click thumbs up if you enjoyed this video.
Adenosine is a purine nucleoside that has several mechanisms of action depending on the receptor that it binds. When adenosine binds adenosine 2A receptors on the coronary arteries, there is an increase in cyclic AMP. Opening of potassium channels and a sharp drop in calcium reuptake, all of these lead to smooth muscle relaxation and coronary artery vasodilation. We are interested in the antiarrhythmic activity of adenosine, which is mainly due to activation of adenosine type 1 receptors, which are located in the atrioventricular node. When adenosine binds to A1 receptors in the AV node, it inhibits the opening of calcium channels that allow the upstroke in pacemaker cell depolarization. Decreasing the conductance of the AV node is useful in treating supraventricular tachycardias because we want to ensure that all of the depolarizations originating somewhere above the ventricles hit the AV node when it is not done repolarizing from the previous signal. This way, the rate at which the ventricles are stimulated is decreased. Adenosine binds to adenosine receptors. These are a type of purinergic receptors. Any molecule that has some attribute of a purine can bind them. Caffeine and theophylline block the effects of adenosine by competing at the adenosine receptors. Well, why is that? This is adenosine. It is literally made up of adenine bound to a ribose. This is caffeine, and here is theophylline. All of these guys are purines, so they can fight with each other at the adenosine receptor. Both theophylline and caffeine look really similar to that adenine group that we highlighted in the adenosine molecule. The similarity of these groups allows theophylline and caffeine to just chill and block adenosine from binding its receptor. The other side effects of flushing, hypotension, chest pain, and a sense of impending doom are all due to the same mechanism: excessive vascular dilation as a result of vascular smooth muscle relaxation. A particularly high yield one is coronary steal syndrome that can give your patient chest pain. Here's a review of coronary steal. The atherosclerotic plaque is limiting flow through this branch of the coronary artery. This segment is already maximally dilated. If we give adenosine, we can only increase the diameter of the normal vessel. As we can see, this will result in increased blood flow into the newly dilated vessel and shunt blood away from the atherosclerotic branch. This can further exacerbate the oxygen deprivation of the myocardium being supplied by the artery with the atherosclerotic plaque. Another high-yield side effect, because it can be deadly too, is bronchospasm. Adenosine can trigger mast cell degranulation within bronchial smooth muscle. This can be very dangerous if it induced smooth muscle contraction. Magnesium is key in controlling the elimination of potassium in the urine and as a cofactor for the ability of the sodium-potassium ATPase. For this reason, magnesium is particularly useful in situations that we may have abnormal potassium concentrations triggering an arrhythmia such as torsades. It is also useful in inducing the sodium-potassium pump to restore intracellular and extracellular ion concentrations. Magnesium is excellent for reversing digoxin toxicity because it will induce the activity of the pump that digoxin inhibits. Remember, digoxin binds here, at the extracellular potassium binding site of the pump. Now we'll discuss ivabradine. Ivabradine selectively inhibits the sodium funny currents. This leads to a prolonging of phase 4 in depolarization. This causes the SA nodal rhythm to slow and also leads to a decreased heart rate without decreasing the contractility, which is great because this causes a reduction in the heart's oxygen demand. This can be used in chest pain like angina that is not receptive to treatment with beta blockers. It can also be used in heart failure with a low ejection fraction because blocking the funny currents lets the heart slow down just enough so that it has more adequate time for filling. And since this drug does not have an effect in contractility, each contraction will be longer and more efficient. There is a visual light disturbance associated with this drug, and since we are slowing down the heart rate, there is an increase of both an overshoot, and we can get bradycardia, or we can end up with a reflex increase in blood pressure.